Welcome. We're just going to wait a few more moments for everyone to sign in. All right. Feel free to hop in the chat and let us know where you're coming from. Welcome. I'll wait a few more moments. Hello, Tennessee. Okay. And we're just waiting for the Zoom recording. Oh, hello. Hey, Bronx, New York. All right. Okay, everyone. Welcome to the triple negative series part 2, body image after cancer. Body image after surgery for Black women. I'm Megan Claire Chase, breast cancer program director at SHARE. So before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. Now, a little bit of housekeeping. All participants will be muted during the presentation, but feel free to, make comments during the chat. But when Dr. Hampton finishes presenting, we will begin the Q&A discussion. And you are welcome to submit your questions during the presentation through the Q&A section at the bottom of your screen. So we can have commentary and stuff in the chat, but please put your questions in the Q&A section at the bottom of your screen. And when asking questions, remember that Dr. Hampton is unable to give specific medical advice, so please keep your questions general in nature. Also wanted to mention that closed captioning is available. You can enable this feature by clicking the live transcript button on the bottom of your screen and then selecting the subtitle option. This webinar is being recorded and will be available on the SHARE website soon. Now, I'd like to introduce you to our amazing speaker. Now, sit back and listen. Dr. Hampton is a board-certified general surgeon with a focus on breast health and breast cancer in the DC metro area. She is the medical director of the Breast Care Center at Doctors Community Medical Center, the first breast center in Prince George's County. She was elected the first female medical staff president in the 40-year history of the hospital, and co-founded and chairs the weekly breast cancer case conference. Dr. Hampton is also the medical director and co-founder of Breast Care for Washington, a nonprofit dedicated to providing access to screening mammography regardless of the ability to pay. She attended the Medical College of Pennsylvania, which is now Drexel University in Philadelphia, and is a member of the Drexel 100 Distinguished Alumni Hall of Fame. Oh my gosh. In 2018, Dr. Hampton co-founded Cherry Blossom Intimates, a bra and lingerie store and mastectomy boutique with products customized for diverse skin tones and body types. Dr. Hampton is the only physician in the country who is a certified mastectomy fitter. What? This proud wife and mother of one son is a Delta Sigma Theta sorority, is a member of the Delta Sigma Theta sorority and the Lynx. Dr. Hampton has been featured in the Washington Post regarding Black women and breast cancer, and in Essence magazine, along with TV and radio appearances on NPR and the Respar morning show. And she's been featured on Own Your Health for breast cancer awareness on the Oprah Winfrey Network. Oh my gosh, Dr. Hampton, we are so honored to have you here. Take it away.
Oh, thank you so much. Thank you, and good evening to everybody. Really just an honor to be here and present to you all. So what I'm going to do is we're going to go ahead and dive right in. I'm going to go ahead and share my screen. And we will get started. So we're going to talk about body image after surgery for Black women. And we can include all women of color as well in this. So let's talk first about triple negative breast cancer. So this accounts for about 10 to 15% of all invasive cancers that we see. It is the most aggressive subtype along with HER2 positive tumors. And unfortunately, as I think it's no secret here to most of the women on this call, it's not responsive to a hormone-based therapy like tamoxifen, Arimidex, letrozole, and the likes. These patients usually have to get chemotherapy as a part of their treatment. But there's been a shift in how we treat triple negative breast cancers. We typically would do surgery first and then do the chemotherapy. And we've shifted to doing the chemotherapy first before doing the surgery. And the good news with this shift is that we have better overall survival with these, what we call neoadjuvant regimens, which is giving the chemotherapy before the surgery. But let's talk about some racial disparities. So this was a study that was done some years ago, and unfortunately still is true, that 5 Black women die needlessly every day from breast cancer. And these are sobering statistics, and I don't like to present this to scare anyone, but I hope that as women of color, it makes us take action and really take a hold of this disease and try and change these stats around. And so what they also found is that African-American women were the least likely of all racial and ethnic groups in the US to survive 5 years after being diagnosed with breast cancer. And again, I think this should really inspire us all as women of color to really take action, and let's be a part of changing these statistics. So let's break down these disparities a little further. So the good news is that as Black women, we develop breast cancer, we have less breast cancer than our white counterparts. So the incidence is about 12% lower in Black women. However, the 5-year survival rate, there's a big difference. It's about 90% for white women and 77% for Black women. And then when we look at overall reduction or decrease in mortality rates over the years, it's decreased greater for our white counterparts by 34%, which is great, but it's only decreased by 2% for Black women. And we know that there are some challenges in that Black women are diagnosed at later stages. We're diagnosed at younger ages. You can see when you break down the numbers, under the age of 50, we as Black women get breast cancer at a higher rate under the age of 50 than our white counterparts. And we also have more triple negative. And so putting all these factors together does make it a little more challenging to make a diagnosis. But again, I think as Black women, we have to be empowered. We have to try and encourage our friends, our sisters, our families to try and get in early so we can get to that early diagnosis category. So now breast cancer treatments over the years have remained the same. Surgery, radiation, chemotherapy are the mainstays. And chemotherapy can be given either before surgery or after surgery, and hormone therapy. But the good news is that within each of these categories, the treatments have actually changed greatly. And that's why we're seeing such higher success rates in just breast cancer overall survival and more survivors. But as you go through the breast cancer journey, we understand there are many decisions to be made. What type of surgery do I have? Am I doing a lumpectomy? Am I doing a mastectomy? What type of medical treatment? Do I get chemo? Do I not get chemo? What type of reconstruction? Am I getting an implant? Am I going to use my own tissue? You know, which doctor do I choose? Who's a good surgeon? Who's a good medical oncologist? Which hospital is the best hospital to go to? And then it's also just trying to manage your life around. What do I do with work? Am I still going to work? How do I manage my children? How do I manage my loved ones? There's so many decisions to be made. And one of the biggest things that people often want to know is, how will I look after surgery? And I think at one time, the medical community thought, well, women shouldn't care what they look like because we're treating cancer. Well, we've shifted our mindset to say, you know what? We can treat the cancer and make women look good. But let's kind of walk through the evolution of breast surgery, because it's quite interesting, you know, how we've gotten to this point. So in the 19th century, they figured out that removing the breast was the way to treat a cancer. And what I really love about this picture is no one's wearing gloves. And if we could see the faces, they weren't wearing masks either. But surprisingly, their infection rate was very, very low. So it's interesting that we have higher infection rates in this day and age where we're wearing masks and gloves and things like that in the operating room. What's also interesting, I think, about this picture is the woman's awake. So anesthesia hadn't quite been at that time. But you can see that how they really need to stop the bleeding. The upper hands are doing, they're actually stopping the bleeding to the breast so that the surgeon could do the procedure. And then they figured out that once you remove the breast tissue, you had to allow for some drainage. So you can see in the picture, the incision is not closed completely because they knew that there was going to be some drainage. And nowadays we use something called a Jackson Pratt drain or some type of drainage tube to do that. And then in the 20th century, a surgeon by the name of Halsted came up with the Halsted mastectomy. And he again agreed, yes, the breast needed to be removed, but in order to really control the disease, we should remove not only the breast, but remove the muscle that the breast lays on, something called the pectoralis muscle. And we should remove all the lymph nodes that the breast drains to, so all the lymph nodes under the arm. He was a little archaic in his instrumentation. When you look at on the right side, what they used to remove the breast, and at least in this picture, the woman didn't have to watch what was going on. Still no anesthesia, so hopefully she got to sniff something or, I don't know, take a swig of something so that this wasn't as painful. What's interesting is that once the breast is removed, patients actually have very little pain, especially if they're not getting reconstruction. And so this is a picture of what the Halsted mastectomy looked like. This really was the mainstay for about 80 years. So you can see on the left, this woman who had the Halsted mastectomy, what you can see through her skin are her ribs, because the muscle overlying the ribs was removed with the breast tissue. And so we thought this was it. This was how we treat breast cancer. Unfortunately, there was a lot of lymphedema, and you can see there in the right side, the patient there has really gross lymphedema going from her fingertips all the way up to her shoulders. But then we figured out, or some smart person figured out, that you know what, we don't need to take the muscle. It's not really adding any benefit, and it really is a more morbid. And so they decided to do a modified radical mastectomy where you actually leave the muscle. And so you can see the difference here. It allows for a little more flatter appearance to the chest wall, which is really great for women who don't have reconstruction. You can lay a prosthesis against there, and it's going to have a little more of a natural feel. And I just love this picture of Shay Sharp, who's all over the internet, a proud breast cancer survivor, proud woman of color who decided not to do reconstruction. And I just love how she's not ashamed to bear her scars and show, you know what, it's okay if you choose not to do reconstruction, and you still can be beautiful. So just kind of walking through the timeline, you know, back in 1894 is when the Halsted mastectomy came about. We didn't start doing the modified radical until 1970. So about 80 years of doing that pretty morbid mastectomy. Again, we were getting rid of cancer, but we just didn't really think about women on the other end of, you know, what happens once we eliminate that cancer? What does she look like? What does she feel like? You can see in the 60s, silicone implants were created. Chemotherapy came into play about 1970. And then it took another 10 years from the modified radical mastectomy for somebody to say, hey, for a woman that has a small tumor, do we need to remove the whole breast? And that's where lumpectomy came about in 1980. And there's a great story of the surgeon who created this. He went to this big medical conference and they really laughed him out of the room when he said, we don't have to remove the whole breast. But, you know, it's not a surprise that they laughed him out of the room because we've been doing mastectomies for 80 years. So that's all people knew. So God bless Bernie Fisher for bringing about the lumpectomy. Then in the 1990s, we started doing sentinel lymph node biopsies where we realized we don't have to take out all the lymph nodes. We can leave lymph nodes behind and just take out what we need. So now sentinel lymph node is the standard of care in most cases. And then in 2010, someone figured out, you know what? We could remove the breast and leave the nipple. And that was quite a controversy, but again, that now has become the standard for a lot of women. So there's something called the Women's Health Cancer Rights Act, and this was enacted in 1998. They decided that, you know, breast cancer patients needed some protection. And so this is a federal law. And what it says is that medical insurance has to cover certain things related to breast cancer and breast cancer treatment, and especially the surgery. So insurance has to cover breast reconstruction, whether that be done immediately at the time of the cancer operation, or it could be delayed, and that can be years later when a woman can come back and get reconstruction. This is her right. It also covers reconstruction on the non-cancer breast. So we want women to be symmetric, and we're going to show some pictures of that. It covers breast prosthetics or prosthesis. So again, if you're a woman like Shay Sharp who chooses not to do reconstruction, well, we can give you a prosthesis so that under your clothes, it looks like the breast is there. And along with that goes what's called mastectomy bras, which are special pocketed bras. I'm going to show you guys some of those. And then it also covers things like post-surgical bras and camisoles as you go through that immediate post-op journey. This law is applicable to all breast cancer patients. Doesn't matter when you were diagnosed, you fall within this federal law. Whether you've had mastectomy or a partial mastectomy, also known as a lumpectomy, this law applies to you. So I tell patients, if you are a breast cancer survivor, you should not have to pay out of pocket for bras ever again. Your bras should be covered in some form by insurance. And there's no lifetime limit. This is, again, applicable to you for a lifetime. So if you're 40, you can get these items to you until you're 99 or even older. And if you have to pay out of pocket, you'll want to check with your insurance company because you should be able to get some form of reimbursement. So let's talk about breast conservation or lumpectomy, also known as a partial mastectomy. We're not going to remove the whole breast. We're just going to remove a portion of the breast. And this is where we're going to remove the tumor and the surrounding tissue so that we can get what we call clear margins. We want no tumor touching the edge of the tissue. And so we're essentially leaving the breast intact. Then we're also going to do the lymph node biopsy where we're going to remove some lymph nodes. And then usually when patients have a lumpectomy, they usually have to get some form of radiation. When you add the radiation to the lumpectomy, that is essentially equal to a mastectomy in this day and age. So you can see from the top pictures, we called ourselves saving the breast, but we didn't do such a great job. I mean, look at our lady on the left side. Yes, we saved the breast, we saved the nipple, but I mean, most of her breast is missing. I know for me, I'd say, just take the whole breast. But, at that time, this was really life-changing for women not to have to experience removal of the whole breast. And then again, on the right side, you can see after radiation, these women would get scarring, and it would scar down and cause dents in the breast. Versus on the bottom is one of our patients who had an oncoplastic approach. So this is a patient, and we'll talk about it shortly, who she had a lumpectomy just like the ladies above, but she got to have something done on both breasts. And now she's symmetric, covered under the federal law. So we've moved to realize, women don't want to look at the scar if we can help it. And so there's something called hidden scar surgery. And this is where we can prioritize removing the cancer, but we also should be able to prioritize the cosmetic outcome. And again, that's just a new way of thinking. And to me, it's the only way that we should think as physicians. And this is where we're going to place the scar in less visible places. So we may hide it under the fold of the breast. We may hide it around the areola. We may hide it really far on the lateral part of the breast. And in some cases, I've been able to do the lymph node portion of the surgery along with the lumpectomy in one incision underneath the arm. And the benefit is patients have less visible scarring. Now, I always joke with my patients and say, I want you all to go run to one of those topless beaches and really be proud, and no one would know because your breast is not going to look any different than anyone else. And so this, of course, results in improved psychological and emotional recovery, improved body image, and of course, self-confidence for the woman. And so we take what's called an oncoplastic approach, where we're combining the onco, which is the cancer operation, with the plastic, which is with a plastic surgery portion. And so we can perform a plastic surgery procedure with our traditional lumpectomy so that we can provide symmetry. And this is really great for larger tumors. It used to be if you had a tumor that was over a certain size, you were predestined to get a mastectomy. Now with this oncoplastic approach, we can take out larger tumors. We certainly prefer smaller tumors, but we can take out a larger tumor and still a woman can get what's called a lumpectomy. So this is a patient where we did what's called a reduction or a mastectomy. So you can see on the left side, the red shows that was where her cancer was. And what's challenging with where her cancer is located is there's not a lot of breast tissue in that area. Usually the top parts of our breasts are a little more flatter than the bottom parts. And so it can be really hard to do a good lumpectomy and give her with a good cosmetic result. And so when I saw this patient, I said, I wasn't worried about the cancer. I knew I was going to get that out. But I said, you know what, have you ever thought of a breast reduction? And she said, oh my God, yes, I've always wanted one. And I'm like, boom, insurance is going to pay for this for you. And we're going to get your cancer out. So you can see on the left, she was a little droopy, a little larger. And on the right, she just looks like she had a breast reduction. You don't know which side her cancer was on. There's no marking that says, hey, the cancer was here, the cancer was here. She just looks like she had a breast reduction. So you can just imagine her emotional, her psychological well-being, and just the happiness. I always tell my patients, I love this operation because these are some of the most happiest surgical patients that we ever have, because they get to have something that they always thought that they wanted and thought that it was impossible, thought it was too expensive. But when we can turn this into their treatment, they just really are happy, happy women. Now, mastectomy, which is still a great operation, and this is just complete removal of the breast tissue. We're going to leave the muscle there. We're going to leave skin there. And the important thing to know is that when you remove either one or both breasts, there's a decrease in risk and recurrence, but that number is not zero, especially if you have a bilateral mastectomy. It goes down to about a 0.5% or 0.5, but that's because there's always a little bit of breast tissue there. And whenever we just have normal breast tissue there, their breast tissue is at risk. Again, quite low, but the risk is still there. So again, you can see a woman here on the bottom after a modified radical mastectomy without reconstruction. Again, another beautiful picture of Shay Sharp. And then I love that women are on this movement of going flat. So there are a lot of women who say, I don't want to do reconstruction. I'm going to go flat. And so they're doing these beautiful things like putting these beautiful tattoos over their scars. And I think it's just wonderful. Now, there are some women who choose to have reconstruction, which is a great option. And reconstruction can be done with an implant, either made of saline or silicone, or we can do what's called a flat-based reconstruction, where we're going to take one's own tissue. Typically, it's going to come from the abdominal area. We're going to use muscle, skin, and tissue. And we can do what's called a tram reconstruction, where we're going to take the muscle, or we can do a deep flap where we're going to leave the muscle, but just take the skin and the tissue. We can also do something called a latissimus flap, where we can take tissue from the upper part of the back and swing that around to create the breast. And there are some very, very specialized centers that do buttocks flaps, but again, very, very specialized centers that do that. And then, as I told you, in 2010, we moved to do a nipple sparing mastectomies, where we can leave the nipple in place. So this is actually a patient of mine. She was at like early 40s, was diagnosed with a small breast cancer on one side. We did MRI to check and make sure there was nothing else. And we discovered a very small cancer on the opposite breast that we probably wouldn't have discovered had we not done the MRI. And so she said, I'm done, take them both. Don't want to do this or go through this anymore. So we did a nipple sparing mastectomy on both sides. So you can see before, she had a little bit of a droop. And then afterwards, she wanted to be a little bit bigger. And she's quite lifted. And her incisions are all hidden scar surgery underneath the fold of the breast and under the arms where we took out the lymph nodes. So when you look at her, you wouldn't know that she had any surgery. This is a sample of a tram reconstruction where we're going to take part of the abdomen along with the abdominal muscle, and we're going to take that to make a breast. We all, most of us, I'll say I do, have that little pooch below the belly button. We all hate it. It really breast, and so we can on the left before surgery is having a bilateral mastectomy. So you can see this is her after having the breast removed. You can see her scar on the abdomen is below the bikini line, and then she had nipple reconstruction with tattooing in order to get the coloring back of the areola. So this is a great option for those who do either single or double mastectomy. Now, of course, with surgery, there can be complications, and that's just the natural thing. So there can be bleeding. Anytime you go through the skin, you're going to have bleeding. But as good surgeons, we're going to stop the bleeding before there can be infection. But we do try to give antibiotics. There can be some numbness and tingling, especially after the surgery. Some of this will resolve over time, but there are some areas that don't quite, the nerves don't regenerate. Lymphedema, one of the dreaded complications that we really don't like as physicians. We're seeing it less and less because we're taking out less lymph nodes and figuring out there's other ways that we can treat the lymph nodes without surgery or with less surgery. And then there can be a change in sensation with the nipple, the arm, and or the breast. You can get what's called a seroma, and that's where there's just buildup of fluid after the surgery, very common. Nothing dangerous, just a little annoying. It can be drained. And then there's scar and scar tissue formation. So let's kind of walk through surgical scars and what that looks like. So we can see this young lady here had bilateral mastectomy, and this is what's known as a skin sparing mastectomy. You can see she has her scars, the nipples were removed, But you can see she has her scar there across the chest. She could also go on to get a tattooed nipple. There's something called 3D nipple tattooing if she wanted to have a nipple and an areola, or she could also have a nipple and an areola reconstructed. Here's another patient who had, again, a skin sparing mastectomy. And what's interesting is a lot of patients who get these, they just want the breast mound. They're not so concerned about the nipple or the areola. And then you can see this is a woman on the right side who had her lumpectomy and her lymph nodes done through one incision. So when she puts her arm down, again, that scar is going to be hidden. So let's break down different scarring that we can see. You can get either keloid scarring or something called hypertrophic scars. And let's kind of walk through to see the differences. So a hypertrophic scar is going to heal. It's going to be wide and flat. A keloid scar, it's going to be wide, but the scar is going to grow up away from the incision. So it's going to be a little taller than our hypertrophic scar. So the healing goes outward from the incision for a hypertrophic scar, and it's going to go outward and upward for a keloid scar. And that's why when you feel a keloid, it feels bumpy and even looks bumpy. A hypertrophic scar can improve over time, meaning that it can get a little bit smaller as time goes on. It can take a couple years for that to happen. Unfortunately, a keloid scar doesn't improve, and sometimes they can actually get a little bit worse and a little more protruded or a little taller as time goes on. Keloid scars are 15 times more likely in those of us with dark pigmented skin. And in some cases, they think that it can be genetic, and that if you come from women and men before you who keloid, there's a high likelihood that you may keloid as well. And the hypertrophic scar is going to occur immediately after the surgery or the injury. It occurs immediately in that healing process. And the keloid scar can occur months or even years after the original surgery or surgical injury. And you can get a keloid after just even a simple scratch or a cut. So again, you can just see the scars here. So the top scar is a keloid. Remember, it's wide and it's growing up out of the incision. And then below is a hypertrophic scar where it's a little bit wider, but it's fairly flat. So how can we prevent these? Well, I recommend that you should show your surgeon any scars that you've had on other parts of your body. So if you've had surgery on your belly or surgery on your arm, offer to show that scar to your surgeon so that they can get an idea of how you may heal from your upcoming breast surgery. And then there are some things that we can do if we know that you're a person, especially if you form keloids. We can inject a liquid steroid at the time of the surgical closure, and that helps to decrease some of that inflammatory response that happens, causes the keloids. We can use something called a heated blade or that has plasma energy. And I've found that really helps to eliminate keloids. When I use that on my patients who tend to keloid, for whatever reason, they don't keloid. We can also do something called superficial radiation, where we can do the surgery and then send the patient immediately to the radiation department, and then they're going to get 3 to 4 days of back-to-back radiation. It's very superficial radiation, not like treatment radiation when we're treating a breast cancer, but it's to the scar, and that helps to, again, decrease those inflammatory responses and that remodeling, and helps to lower that keloid formation. And then there's something called silicone sheets. I've heard people use these. I know some of the plastic surgeons use these. There can be some mixed results, but could be worth a try. And then, of course, you can get scarring after radiation. So when you're getting radiation, the skin will get darker over time. It's almost like you're getting a suntan over the 4 to 6 week time period that you're getting your radiation. Black skin can react a little more than white skin. And, I hate when people say, oh, radiation burning. What I found helps is to hydrate the skin prior to getting radiation. So immediately after surgery, and when your surgeon says you can, start to use a thicker lotion, shea butter, There are a lot of creams. I have a colleague, she has something called Burn Butter. It's called Dr. Shorty's Burn Butter. It's a concoction. I know it's got some shea butter, some cocoa butter, some vitamin E, and some other things in it. And I have my patients use this leading up to radiation, and you can even use it during radiation. It helps to keep the skin soft so that the skin tolerates the radiation a lot better. So breast reconstruction, while it's great and we have great results, it does have complications. About 1 in 3 patients will have a complication. Usually the complications are minor and can be treated usually without additional surgery. About 1 in 5 patients will require additional surgery, and that could be just modifying, revising the area. And then about 5% will fail completely, meaning we just have to take everything out that we reconstructed and close everything down, and then wait and delay to try again if the woman chooses. And there are a lot of factors that lead into this. So it could be patient selection. So some patients are just not real healthy and probably shouldn't undergo reconstruction. Medical problems, blood pressure. If you're gonna be a good candidate for reconstruction, you've gotta have your blood pressure under control. Otherwise, high blood pressure can cut off the blood supply to the flap, especially if you're doing a flap. If you're diabetic, you've got to keep that diabetes under control. Blood sugar, high blood sugar is a nidus for infection, and bacteria love sugar, just like we love sugar. When you have high sugar levels in your blood, the bacteria start to have a field day, and that can affect your reconstruction and cause really bad infections. And then smokers, because smoking can constrict and close down the blood vessels, and we want blood to get to that healing area. So the body condition makes a difference. Some patients may be malnourished, and so reconstruction is not a good idea. And then just the psychological well-being. Sometimes patients are just so overwhelmed and all these choices they have to make. And I know I've had some real conversations with patients to say, if reconstruction is not the right thing for you today, guess what? You can come back in a few months. You can come back a year later, 2 years later, 3 years later, when it's a better time for you. And I found that just really helps with patients emotionally, and it helps to just kind of take the weight off of them and trying to figure out, do I want silicone? Do I want saline? Am I doing a flap? It's just a lot to take on, and it's overwhelming. But if patients don't want to do reconstruction, or if they have failed reconstruction, then they may want to look at doing a prosthesis. So what are the benefits of a prosthesis? Well, it doesn't require any additional surgery. It can be used as a temporary bridge in between reconstructive surgeries, especially women who are undergoing expanders, where we need to expand the volume, stretch the skin out. We can have special prosthetics that can help during that time, so that, again, you can have that symmetry under your clothes. It can be used to help restore lost volume, and it can just provide confidence for the patient. So you can see here some different types of prosthetics. So there's a partial. So some of those women we saw earlier who had that kind of half breast after a lumpectomy could use a partial prosthetic. We have something called an active form, which is just a soft form that a patient can use when she wants to exercise. And then we have something called a layered prosthesis. And this can be used for those women who are undergoing reconstruction, where we temporarily put in an expander to get prepared for an implant. And so the expander is deflated at first. She can use the full volume prosthesis. And then as we expand her and stretch that skin, we can peel away these layers to this prosthesis, and she really can use it as she needs it. So what does it look like when you have a prosthesis and a bra? Well, you can see the bra. This just looks like any old regular bra that any of us would wear. The difference is it has a pocket, and it has to have the pocket if you want to have it covered by your insurance. So this pocket is very, very important. So you can't just go buy a regular bra and expect your insurance to reimburse you. And you can see here, we take the prosthesis, we fit it into the pocket, adjust it a little bit, and then she puts her bra on. And so when you look at her under her clothes, she just looks like she has 2 breasts there. So these bras come in all different styles. They really have upped their game in the mastectomy world. and really created more beautiful bras so that the patients can feel more normal. Now, there's something called a standard versus a custom prosthesis. So you can see the differences here. So standard, they come in two colors, sort of a brown or cocoa color, or a peach or a pink color for our white counterparts. And this is versus a custom prosthesis. So a custom prosthesis is actually made to the individual woman. We can color match it. We can put a nipple on it. Some people choose not to put a nipple on it. It can really take up the volume that the patient needs, especially if she's had a not so great result from either reconstruction, or if she's one of the, again, those earlier patients who have that kind of half breast, it's dented in. The custom prosthesis is a great option. And you can see it comes in all these beautiful colors. And I say, you know, we all have so many different shades to our skin tone, even white women. White women are not peach or pink. They have peaches. They have different shading to their color. Asian women have different shading to their color. Latino women. So the great thing is we can color match almost anyone's skin tone. And then the other fun thing is they can choose a nipple. Do they want a big areola or a small areola? You can even select the protrusion of the nipple with this. So it really is you pick it, you design it, and we will create it. So what happens is we do a scan process where a woman comes in and we scan her both with a bra and a prosthesis on, and then we take everything off and scan her. And then this is what a custom prosthesis looks like. So this is one of my ladies here. You can see she had reconstruction before, had to have it removed, and decided she didn't want to go through it again. So she got a custom breast prosthesis. So you can see she got to pick out the color. It's a pretty good match. She picked out the nipple and the areola. And the difference with this compared to the standard prosthesis is this is going to fit right against her skin. So the nice thing is she doesn't have to wear a pocketed bra. She can just wear a regular bra. And when you look at her on the right side, you can see she just looks like a normal woman. And what is cool about this is when you look at both sides, the kind of the nipple protrusion is matched. So this really is a customized look for her. So this is just another patient that has a custom prosthesis, and you can see we can really color match. The patient on the right here, she just had some volume deficit in the bottom. And so that's where we created her prosthesis. She puts this on, puts her bra on, and can walk out in the world and feel good. So again, I talked about insurance coverage for this. So again, it has to be that pocketed bra. Can't just go to any old bra store and get a regular bra. It has to have that pocket in order to cover it. Medicare, they give 12 bras for a year. These get three months. As a breast cancer patient, these patients should not pay for bras out of pocket. Commercial has no stated limit. We always have to look at what the coverage is. The silicone prosthesis, you can get one per breast every 2 years, and this includes the custom. And then the non-silicone or that active form, this can be replaced every 6 months. And again, I just encourage women to check their insurance to determine the coverage. There's some insurances that are going to cover this at 100%. There's some, they go by what your deductible is, if there's a co-insurance or co-payment. In order to get it, there's some required documentation that's required. You need to have an order from your doctor. You can't just walk in or insurance won't recognize it. So you need a special order, and there's a sample of one there. Doctor just checks a couple boxes and signs it, and this qualifies you to be able to get the items. And then you usually need a note from your doctor or your provider just stating that you have breast cancer. And then there's a proof. We have to show that the items that ordered for you were given to you. And then if you choose to get a custom, there's just one other piece of document called a certificate of medical necessity that's needed. And so how do we move forward as survivors and thrivers? Well, I think it's important that you find providers that make you comfortable. I can't stress this enough. I mean, it's okay for you to shop around for doctors. I think, you know, we're discriminating when we buy shoes and clothes, Well, we're talking about treating our body. So we should be discriminating and we should ask questions, consider getting a second opinion, really getting that good vibe with your breast cancer treatment team. Ask questions. If you have providers that aren't willing to answer your questions, aren't willing to talk to you about what the surgical procedure is going to be like, give you some realistic expectations, and you need to find another provider. Ask about the surgical details. What's going to happen? Not just how long is the surgery, but where do you propose putting my scarring? Well, what if I want my scar a certain place? What if I want to be a different size? These are things that you really should talk to your surgeon about. And really to consider all the options. I know there's certain treatments, a lot of people don't want surgery or a lot of people don't want chemotherapy, but I think it's important to just hear all the options. Again, get a second opinion if you need to, but really to consider all the options and think about what's best for you. And we're really in this era of very personalized care where it's not a one size fits all. It really is looking at each individual woman, speaking to her about her goals and objectives, and then coming up with a plan that meets her needs, but also gets her treated within the standard of care. So with that, I'm going to say thank you all so much for tuning in. And I look forward to taking some questions and hearing from you guys.
Hello, Dr. Hampton. Oh my gosh, that was an amazing presentation. Just seeing images that look like us it's very emotional, quite frankly. We did receive some questions prior to the presentation beginning, but we did get one live here, and you did already go over it. Her question was, she got a double mastectomy with lymph node removal. How do I get my insurance to cover my bras? And you mentioned check with insurance and needing the documentation from your provider, but should the patient be the one to call their insurance, or is it something that someone on our medical team can do on our behalf? So, you can take out that middle person?
So I think it depends on where you go. Now we do at Cherry Blossom Intimates is that we do that billing piece because we know that's quite overwhelming. So, we do check the benefits, and there are some other mastectomy salons that do that. Really excited to share that we now have virtual option as well. So we can do that virtually. We can do the fit virtually. And that's called Maya, MYYA, and that's a division of Cherry Blossom Intimates.
Wow, virtual. Well, that goes into another question that we have. Where are the best places to have custom breast forms done? This person doesn't live in the US and they just need some guidance.
Yeah, so you can check. There are some companies. True Life is a company. American Breast Care is another company. These are companies that supply prosthetics and do custom. And so I think on their websites, they have lists of providers that do the custom prosthetics. I know True Life, their custom prosthetics are actually made in the UK, in Ireland, I believe. And so you can check with them and see if they may have providers in the UK or Europe that can supply that.
Oh, fantastic. Thank you. Some other questions here. So someone you mentioned about, your care team and how important it is, to find the right fit. But here's a question. If we don't have anyone Black or a person of color on our medical team, what are some questions that we should ask that are specific to Black women when deciding what type of breast cancer surgery to have if there is a choice?
Yeah, I think it's important to talk about, scar placement. I think if there's certainly concern about keloids, having that honest conversation, seeing if there are some things that the surgeon would recommend to help lower that risk of the keloid formation. I think saying, hey, I'm really concerned about scars that are visible. What can you do to hide my scar or place it so that if I am going to get a keloid, at least it's in a place, where it's not seen. And could you consider doing my surgery and putting the scar in a place that's less visible? So I think it's just having those kind of open and honest conversations with your surgeon, to see what he or she thinks, and see how they're willing to work with you.
That's key right there, right? So how do you help prepare Black women emotionally when the bandages come off and they look at their scars for the first time? Even if it's a hidden scar, it's still a scar that they will still see. What are some ways that you help prepare them for that moment?
So one of the things that I tell patients is that, what you see after the bandages are removed is not going to be the final result. Like it's still a journey. We've got the cancer out. This is the first part of the journey. And so, it's going to look different, but it's not going to be the final look. And so it's just going to take us some time to get there. And so, to just kind of get your mind that this is not the final look. And so realizing I just have to kind of go a little bit further to get to that end result. Yeah, and it can be very emotional. And I know a lot of patients that say, well, I didn't look, I didn't do it in the mirror. I had, my significant other or my husband do it because I just was afraid to look. And then, one of my patients who we did the oncoplastic approach, we showed them like, it's going to look like a breast vagina. And she didn't look at it for weeks. And then when she finally looked, she was like, well, what was I afraid to look at? I was like, I don't know. It was great. But I get it. It is a very emotional journey, and going through that. And, I think people kind of in their mind think the worst, or they have this, movie-like thing, like it's going to look like Frankenstein or something big and scary. But, I think, again, we've just changed to realize, we've got to do better than we have in the past. And so we've pushed ourselves as surgeons and, this hidden scar technique and the oncoplastic technique. And it's actually fun. I love it.
Wow. I have some more questions for you. Why is it important to keep scars out of the sun? Some people I've heard of this as well, like where some of their surgeons have been like, maybe you've got radiation burn, or even like if you want to go topless or something. Is there a reason why we should cover that and not have it, be protected from the sun?
Not to my knowledge. I mean, I think once you're out of the immediate, out of the treatment process and you're, healed, I mean, I think it's just like any other part of your body, then, using sunscreen or sunblock. But I am not aware that surgeons or folks are telling people to stay out of the sun. I don't know. I'm like, go show them off. I mean,
oh my goodness. So
I think I guess the answer would be check with your doctor and see what your doctor said.
Right. Interesting.
Ask the question, ask why, and say, and how long do I need to adhere to these recommendations? But I don't know of any medical reason why people have to stay out of the sun. It might be one of those kind of old wives' tales that doctors just won't let go. So
right, like
yeah, we have those
a regional thing or something wherever that person is from.
Yeah.
So here's a question. Saw on your slides about lymphedema, and like, is it more prevalent to get lymphedema if you have a mastectomy versus a lumpectomy, or is it really based on the number of lymph nodes removed?
Yeah, it's based on the number of lymph nodes and any additional treatment that you get. So if you've had, more than 20 lymph nodes removed and you've had radiation, then your risk of lymphedema is going to be certainly higher. If you've only had 2 lymph nodes removed and you have radiation, then your risk of lymphedema is going to be a lot lower. And we've just lowered the risk for lymphedema. I think we've gotten it down for a sentinel node to be anywhere from 8 to about 12%. And I think it's even getting lower as we are just changing some of the things that we do. There was some new recommendations that came out some years ago that showed even if you do a sentinel lymph node and say you have one lymph node that's positive, but the other 4 are negative, you don't necessarily have to go back and remove more lymph nodes. You can turn around and possibly give that patient chemotherapy because the chemotherapy will work, or to do radiation. So we're just really having some different conversations about lymphedema. We're still haggling over them as well as providers. I was just at a talk last week where we were talking about lymph nodes and lymph node removal, and it's just ever changing.
Wow. Let's see, what was that other question? What should this was another one. What should be considered when getting tattoos to cover the scars? We saw that one beautiful slide of the tattoos over someone who is flat. Is there anything that patients should consider when getting tattoos over their scars?
No, I think certainly waiting until the area is well healed. I would say wait at least a year, and making sure that it's totally healed. But I think beyond that, I think it's fine to do and get one. There shouldn't be any problems once everything is healed.
Okay, and then what is that other one? So, what are some things that Black women should consider when specifically searching for a breast cancer and plastic surgeon?
I think, really looking at someone who really is going to listen to you, is going to really work as a partnership. I find sometimes patients come in with their own ideas about what they want their treatment to be.
Mm-hmm.
And I think as a provider, it's just important that we listen, that we respect the fact that somebody may have, they may just not know or understand. They may have been fed a lot of misinformation. And so it's really taking that time to really explain maybe why what they want to do is not quite the standard of care and why we're recommending the standard of care. So I think it's really trying to just find people that, I think it's a vibe too. I think it's if you walk in and you start to have a conversation and you're just not feeling comfortable, and that could just be, I don't know, just this person, I don't really like their philosophy about lumpectomies, then go get another doctor.
Mm-hmm.
You can fire a doctor. And I think, again, we choose our shoes, our cars, we choose everything, our produce, but we don't take that time to choose our doctors. And I think it's important to realize, you have a little bit of time to choose. And I think no longer do we realize, okay, we're going to diagnose you on Monday and we should be doing your surgery on Friday of the same week.
Right.
If somebody's recommended to walk out. I think it's realizing, there can be a little bit of time to give people to just process the information, to explore all the options. And I think it's, as a provider, I feel like, again, it's my job to just be open. I've had a lot of patients who, they just disagree with, they don't want to get chemotherapy or they want to do it this way. But I think I always find to leave the door open so that even if she chooses to come back, then she knows that I'm at least there to listen. And at some days I'll say, you know what, we just disagree, but I still want the best for you. And many times patients will go away, they'll think about it, and then they'll come back and say, I just really appreciate the fact that you left the door open. So, I've had patients who wanted to try all kind of things. And I say, well, okay, here's the recommendation. This is what I recommend. And they'll say, well, I want to go try, I don't know, pomegranate juice for 3 weeks. Okay, we'll come back in 3 weeks. Let's have another conversation. And so it's just really leaving that door open. I know for me, that's just something that's important. And I think it's important that you want to go to someone where you feel heard. And as a provider, they may not agree with your methods, but at least if they hear you and at least leave the door open, I think that's so important.
I love that. Everyone, I want to leave that with you all. Like when you're talking with your providers that, I hope they leave the door open for you. Thank you so much, Dr. Hampton. This was an amazing presentation. Thank you for all that you do and continue to do. And I want to thank all the attendees tonight for participating and submitting questions. I want to make sure that you check out our upcoming breast cancer programs. Feel free to share these programs with your communities. Your friends and family are welcome to attend. You don't have to have breast cancer to attend a webinar because it's all about education as well. Knowledge is power. And then also make sure to follow us on social media as well. Please take a moment to fill out the survey at the end of the webinar. The survey will show up in your browser when the webinar ends, and the link will also be in the follow-up email, and all surveys are anonymous. This concludes our webinar, everyone. See you next time, and thank you again for coming. Bye.